want to step over here for just a second. So we're gonna hit these protocol changes a little bit more in depth this month to get us all up to speed. So number 4, rapid sequence intubation has been changed to airway drug assisted. So because it's not necessarily a rapid sequence intubation protocol anymore. Nothing has changed as far as most of this protocol goes. Indications for RSI: failure to protect the airway, unable to oxygenate, unable to ventilate, impending airway compromise. Need a couple IV sites, get your equipment together, and then protocols 1, 2, and 3 should kind of be used together. So the main thing that's changed is here. So there's a decision point here that wasn't on the initial RSI protocol. So hypoxia or hypotension or dangerously combative. And dangerously combative means really dangerously combative. So not just a punk and not being nice. I mean, it's somebody that's really absolutely out of control. Multiple people are on board trying to get this patient under control. So, but this decision point, if it's no, if they're not hypoxic and they're not hypotensive and they're not dangerously combative, it kicks you to the left side of the algorithm, which is still, this is nothing but the old RSI protocol, right? So etomidate, ketamine, sucks, rocuronium, intubate, capnography, consider restraints to keep them from pulling the tube out, consider a gastric tube, and then after we've got the airway secured. We were able to do this before, but it was unclear from the state, so we had confirmed from the state that ketamine was fine to give as a sedative. So you can use ketamine as an induction agent here, and then you can repeat ketamine after the airway secured if you need sedation. All right, any questions about that? So that is a change, but we apparently could have done that before anyway. Fentanyl, we changed. Crap. That's all right. It's tough. Yeah, it's not a tough book, but let me put it over here. I still got a screen. Ah, crap. Maybe it's not as tough. Maybe it's not as tough as I thought. There we go. That's waking up. It just had a concussion. Yeah, maybe.
Are the protocols you're going over now not updated on the Dropbox?
Not yet. I hadn't put them there yet till we all go over them. Hang on one second. Let me reboot this thing. Hopefully that'll work.
We got a second training this month. After that, we'll look at going and implementing this. We need to get everybody through this training.
Plus we've got drugs that we need to make sure we've got too. Adding a few new drugs. Give me 1 second. Let this thing reboot. It rebooted. That's a good sign. All right. Sorry. All right, so after ketamine, the dose is 1.5 to 2 mg per kg, IV or IO. And then fentanyl, the changes we made here, we made it 50 to 100 mics each dose. You can repeat 25 to 50, max 500 before you'd call medical control. Morphine did not change. Versed did not change, 2 to 2.5 mg per kg, max 10. And then consider a long-term paralytic, but remember, we only want to paralyze somebody if we can't get them sedated with first opioids. So most of the time they're combative because they're in pain. So opioids first. Or ketamine is actually completely fine and would really be preferred agent because it not only is a sedative, but it's a pain reliever as well. So one of the things that's removed here is lidocaine. So lidocaine is no longer in this algorithm. We don't need to give lidocaine anymore. It's the literature that it worked is actually pretty low anyway. So lidocaine's off this algorithm, so you don't have to give lidocaine anymore. All right, any questions about this side? So this side really not changed much except for the addition of ketamine, change the fentanyl dosages, and lidocaine is now gone.
Just ketamine one time though, because I don't see anything about repeat dose on ketamine.
Correct. I'd call you probably wouldn't if you dose that ketamine appropriate, you probably wouldn't need to repeat a dose. I'd call or that, or you can give, or I'd give fentanyl. Yeah. So fentanyl and ketamine first. Prefer that over morphine, and Versed last resort. Folks who get a lot of benzos actually have worse outcomes in ICU, so we're much better off giving ketamine and fentanyl. All right, so now, if they are hypoxic, or if they're hypotensive, or if they're hypoxic and hypotensive, and they need an airway, then we get kicked over to the right side, which we're going to give ketamine, 1.5 to 2 mg per kg IVIO, and then that's going to exit us out to the adult airway or adult failed airway protocol. So forget about dangerously combative for just a second. So what that means is ketamine now gets moved over to the left, and it takes you out to the adult airway protocol. So you can give ketamine, bag valve mask, so you want to correct that hypoxia. You can use a blind insertion airway device. You can use an OP or an NP. So those are what we're going to use on the left side of the algorithm. The ketamine is to get somebody sedated that will maintain their respiratory reflexes so that we can resuscitate them either if they're hypoxic or if they're hypotensive. All right, any questions about that? So I don't know what you guys did years ago. I can tell you when I took over Stokes, they were giving Versed and trying to intubate. There's no worse approach unless you want to kill somebody than going through that approach. So if I don't know what you guys did, but if you were doing Versed before me, that's actually kind of what we did. But ketamine is a much, much safer agent to use. So ketamine takes you just out to the adult airway and adult airway fail protocol. So ketamine, resuscitate, and then once you correct that hypoxia or correct that hypotension, remember the arrow goes this way so that now it will bring you back over into this side. So you could continue down this algorithm and just finish out the RSI once you've got somebody stabilized from a hypoxic or hypotensive standpoint. All right, any questions about that? That particular section. Correct. There's no, if you've got a stable airway, let's say you've put a blind insertion airway, you've got a keying in, you've got ketamine, you've got a keying in, their SATs are normal, their end-tidal CO2 is good, their bag compliance is normal, there's no reason you have to come to this side of the algorithm. You can. It's an option, but you don't have to. So it's absolutely acceptable to use ketamine, put in a blind insertion airway, and you're done. But it's also acceptable to come this way. So I'll leave there has to be some judgment, so that's where the judgment comes in.
Question about that. If you got them sedated, you got a tube, whatever, and they become aggressive, where's yours? You want to go back to here, or you just want to go back with some fentanyl?
So you've got them, now let me make sure, so you said you got them tubed. Are you saying you got an endotracheal tube in, or you've got a blind insert, got a keying airway in? So if you've got so you have gone to the ketamine route and you've placed a blind insertion airway and now they've become combative, that actually would be a good reason to maybe pull you back to this side of the algorithm. Just go ahead and actually perform an RSI. You could repeat your ketamine, give them succinylcholine or rocuronium, and then intubate them. All right, so that would be one example where you could that actually would bring you back to this algorithm. If you had a good airway but they got combative and you were worried that you're going to lose your airway because they are combative, then you could come back to this side and go through the RSI protocol.
They weren't combative, okay? You just want to maintain an airway. Where would you go?
Yeah, if they're not combative and you've maintained their airway, you would be fine.
Running out of the ketamine.
Well, I mean, if you're dosing ketamine 1.5 to 2 mg per kg, that's going to give you about 20, 25, even maybe 30 minutes of time. So if you dose it appropriately, it's going to give you a fair bit of sedation time. Yes.
Nelson, if you start, we'll say you start with etomidate, can you redose it one time like ketamine or not?
Yes, you can. You can. So you can repeat the,
Start with one staple.
right, you can repeat those again. Christy.
I was just saying it would be nice if they would have hooked that box on the right back down to that middle there. I can't read it, I'm sorry, but they would have come back down, come down and bam, and right back in there, then let you go through. If you have re-movement and reawakening.
So if you have a blind.
Oh, but you can. But you can. So remember, if you're over here, and you've got, let's say Eddie's example, let's say you got a king airway in and they got combative. So yeah, you can come back over here and then move to this side. So you can actually come down here.
Just to sedate.
Yeah. So you don't have to do that, right? Yeah, you don't have to do that. Remember, the protocols are written in a box form, but you don't always going to follow that box. You might skip down and then go back. It just has to be written in some form, and you can't anticipate every. But yeah, that's a good question. So you've got ketamine, you've got a king airway. They become more combative. So you can go back into this algorithm. You could complete RSI, or you could redose and give a sedative. As long as because if you got a controlled airway, you're golden.
Dr. Nelson, does etomidate need to be added in with ketamine like it is at top, ketamine or etomidate to stay within the protocol? Within the purple?
You're talking about sedation after.
Like one-time additional sedation with etomidate and ketamine since it just.
Oh, so no, you would not give etomidate just for sedation. So etomidate, you can give, let's say for example, you're going to give etomidate and succinylcholine and do RSI, and for whatever reason you weren't successful and you wanted to go back and repeat it. Your airway's fine, you're able to bag, you can ventilate, you can oxygenate, but you want to go back and do the RSI procedure one more time. So then you could repeat etomidate and succinylcholine. But then once you're down here and you've got an established airway, then we don't use etomidate to sedate. Okay. And the reason is multiple doses of etomidate, there's this theoretical risk where you may suppress their adrenal gland. So we don't want to do that. That's really theoretical, and we get into that more in the hospital. But if anybody's going to be blamed, it'd be us by giving a bunch of etomidate. So we've got plenty of tools down here to continue the sedate. Ketamine, to me, is actually one of the better sedative agents out there. It's safe, protects your airway reflexes, little side effect. So ketamine is actually a great alternative, and I'm glad we can use it after either over here to establish an airway or here for sedation after we've got an airway established. So good questions. But yes, you can move back to this side of the algorithm. You can complete an RSI, or you can move back to this side of the algorithm to give sedation. All right. Any other questions? Yes.
You were using the right side there, the example of like a blind insertion. Let's say you got somebody and they're down, maybe they're hypoxic, and we just end up straight out intubating them.
Mm-hmm.
Is that okay as well?
Yes, ma'am.
And we've had them.
Yep.
They awaken and
Yep.
and sedate them back out with some ketamine.
You can. So in that, when you move to the right, and I should have put the adult airway protocol up here, but in the adult airway protocol, intubation is in our adult airway protocol, not just the RSI. So yes, you could give ketamine, and you could do intubation. Yeah. I will tell you though. So in general though, the reason we do RSI is because RSI is going to give us the best conditions for intubation, right? So it's going to sedate you, it's going to paralyze you, it's going to give you the best environment to do intubation. However, there are going to be patients, especially elderly patients sometimes, you give them a slug of ketamine and absolutely you'd be able to intubate them without any paralytic at all. And honestly, that is safer. Especially for pre-hospital or even in the emergency room sometimes, if we are patients unknown, you haven't had a chance to do a complete difficult airway assessment, yes, perfectly acceptable to give them ketamine, and if you can intubate them, absolutely, because that is safer than paralyzing someone. So We get best intubation conditions over here. You know, we've gone through our algorithms. We've anticipated difficult airway. We've got them in the correct position. So this is the best case scenario. But if you get them in the best position, you've done your difficult airway assessment, you give ketamine, you absolutely can intubate on that side of the algorithm. Intubation is part of the adult airway protocol. So this just gives us another tool, but remember the main branch point is here, is the hypoxic and hypotension. So we know in North Carolina, 1 out of every 22 people that get RSI die. And if they're hypoxic or hypotensive, the chance they're going to die goes up almost 10 times if they're either hypoxic or hypotensive. So that's why we've added this algorithm to give us one more tool to let you resuscitate that patient and not be forced to run down the RSI protocol. Because folks, when they're hypoxic and hypotensive and you go down this protocol, most are going to arrest within 15 minutes. So that gives us a tool to gives us a chance to manage the airway, correct the hypoxia, correct the hypotension, where it makes it more safe to do RSI if you go down this RSI protocol. But you could intubate them, and you could continue with a King airway. You could even continue with a nasopharyngeal airway or oropharyngeal airway and a bag valve mask over here once you've given them ketamine. If you give them ketamine and you can maintain their airway with an NP or an OP and their SATs are 91%, 90%, 91%, you're fine. I mean, you're maintaining their airway, they're oxygenating, they're ventilating, and you've got an airway established. So this just gives us more choices, more tools to use and not force us down the RSI protocol when folks are going to have a bad outcome by trudging down that protocol when they're unstable. A good example was the other night with the crash that was on 601 where the teenager was hypoxic when he was first found. So crews did a very good job of bagging that guy up before they ever attempted RSI. So his SATs got way above 90%. He was hypertensive. That wasn't an issue. But no one just gave him etomidate and succinylcholine and trudged down this path with RSI, because we know in North Carolina when we do that, most of those folks die. So this kid was given every chance. He had horrible injuries, but he was given every chance from an airway standpoint. Bag valve mask was utilized. We corrected his hypoxia, and then we did RSI and had no issues with the RSI. RSI was fine. All right, any other questions about that?
Now, we're still going to do the roundup, the numbers.
Yes.
Okay, so
Yeah. Yes, don't make it too complicated. Again, I don't ever stand at the bedside and give somebody 21 milligrams of etomidate and 172 of sucks. That's crazy. Just round them. So again, I just gave you examples here. It doesn't even have to be exact, but you know, if you're going to give, because honestly what I've seen is most folks got the etomidate dosing right. The succinylcholine is what they got wrong. The etomidate's much harder to figure out, right? Because it's 0.3 mg per kg. Sucks is 1. So folks were getting the etomidate right, but the sucks wrong. So if you're going to give 20 of etomidate, give 100 of sucks. 25 of etomidate, give 150. 30 of etomidate, give 200. 35 of etomidate, give 250. And then 40, give 300. Remember, the safety profile of succinylcholine is huge. So we're giving around 1 to 2 mg per kg. We don't get into trouble until you get beyond 6 mg per kg. So we still are well within the safety profile of succinylcholine. Good question. All right, any other questions about airway? All right, not a lot of changes, just more tools. Ketamine's a very effective tool and will allow us to manage an airway without being forced to go down an RSI pathway that they may not need, or may need a little bit of resuscitation before we go down venture down that path.
One more question.
Yes, ma'am.
Do we only need to complete the airway form if we travel down the left side?
No. Anytime you give drugs, so for this, and for me too, so if you intubate someone like, I know, they still got a pulse, but they're completely out of it, and you don't need any drugs, and you intubate that person, no, you don't need to fill out an airway. Some services want you to do that, but I don't. So for the airway form, it's anytime you use a pharmaceutical. So if you use a drug,
Before the fact or after the fact of those?
before. So if you use a drug, fill out the state airway form. Yeah.
On the adult airway, Dr. Nelson, it shows after, if we tube them either blindness or AT, it says Versed. Are we gonna add ketamine in there for sedation? Not DIA, but.
Yeah, no, thanks.
DIA, but.
Yeah. Yeah, thanks for telling me that, because honestly, it's been so long since I've looked at that protocol, I forgot. I will change. I'll need to change that. So we'll change it. Basically go back to mirror what we've got over here. whoops. Which direction am I going? Basically just remove, we're still using this.
Okay, so that'll get
So
added
it's-
to the adult area.
Yeah, thanks for telling me that. I do need to change that.